Hello everybody. Now we meet again here today and I'll be talking about the second part of myofunctional appliances. Now the learning outcomes is the same as the earlier lecture, and today we will be looking at the design indications and contraindications as well as clinical scenario in which various types of myofunctional appliances are used. Now, a word about visual treatment objective. Now, visual treatment objective or VTO can be a useful diagnostic test to decide the patient's suitability for treatment with myofunctional appliances. Now, this involves visualizing the change of the patient's profile after treatment. The patient is asked to protrude the mandible into a age-to-age incisor relationship, and after doing this, if the profile improves, it means the VTO is positive and the patient is suitable for treatment with myofunctional appliances. So here is a graphical example of the visual treatment objective. As you can see in the second photograph on the right, the patient has protruded mandible, and we can see that there is an obvious improvement in the facial profile of the patient. So this patient has a positive VTO and will be suitable for treatment with myofunctional appliances. Now, the simplest myofunctional appliances are probably the bite planes. There are few types. One is they can be either anterior or posterior bite planes, or they can be flat or inclined bite planes. Let's have a look at the flat anterior bite plane. Now, the flat anterior bite plane, this occludes the posterior teeth. Now, the effect of this is there is a differential eruption of the posterior teeth with either the lower incisors being intruded or the least it is held from over erupting. Now, this results in a reduction of the overjet. The disc occlusion of the mandible also encourages growth of the mandible, and with the buccal teeth eruption, there is an increase in the lower anterior facial height, which tends to reduce mandibular prognathism. Now, the flat posterior bite plane. Now, this causes eruption of the upper molars, and the molars move vertically and mesially. Yeah, so this is what normally happens without a bite plane. During eruption, the molars will move vertically and mesially. Now, the effect of the posterior bite plane is to impede the eruption of the upper molars. Now, this results in greater anterior movement of the lower buccal teeth, and this tends to improve the class 2 molar relationship. Now, the vestibular screen was introduced by Neville in 1912. Now, it's a curved shield of acrylic placed in the labial vestibule. It relieves the forces of circumoral musculature, and which causes the tongue force to be unopposed. So therefore, the action of the vestibular screen is both force application, whereby the force of the tongue is utilized, and also by way of force elimination, whereby the effect of the lips are restricted by the vestibular shield. Now, the indications of the vestibular screen are to stop mouth breathing habits, and it is also able to stop other habits, and it can be used in mild class 2 malocclusion as well as where there is a mild anterior proclination of the anterior teeth. Now, to fabricate the vestibular screen, cast should reproduce the depths of the vestibular sulcus. And for class 2 correction, the construction bite is taken with the mandible in a advanced position. Now, the flange is extended to the full depth of the sulcus, and the screen can be made from either self or heat-cured acrylic. Now, the patient is expected to wear the appliance full night time and about 2 to 3 hours daytime, and the patient is advised to maintain lip seal while using the appliance. Now, the vestibular screen can be modified in various ways, one of which is a Holtz modification, whereby a metal ring is projects between the upper and lower lips. Now, this metal ring can be used to conduct various muscle exercises. Now, the second modification is to put an additional screen, as you can see here, on the lingual side of the teeth. Now, the idea of this is to break tongue truss habit. Now, the third modification is to put perforations in the screen. Now, the idea of these perforations is to break the mouth breathing habit, and as the habit changes, there's a phased closure of the holes in the vestibular screen. Lip bumper. This is also may be known as a lip plumber. Again, it works by either muscular force application or force elimination. It holds the lips away from the teeth, which can be upper teeth or lower teeth, but more commonly it's used in the mandible. When it's used in the upper teeth, the modification is known as a Denholz appliance. Now, the lip bumper is used to eliminate lip habits, example lip sucking, and it holds the lower lip away from the teeth. It can be used to correct an hyperactive mentalis muscle, which helps to reduce crowding of the lower incisors, and also by it reduces the overjet by forward movement of the lower incisors. Now, since it's attached to the lower molars, it prevents mesial movement of the molars, okay, which can increase the anchorage value of the molars. It can be also be used to distalize molars, which the effect is usually minimal, and it can be used also as a space regainer. Now, the lip bumper is fabricated from a 0.9 mm stainless steel wire extending from molar to molar. It's inserted into molar tubes soldered to molar bands. Now, the anterior portion from canine to canine is covered in acrylic. Let's have a look at the ENT Activator. This was introduced by Viggo Anderson in 1908, and it was later became known as a Norwegian appliance, and it is called an activator because it activates muscle forces. Now, the activator is a monoblock type of appliance. Now, what are the indications for an ENT activator? Is used in actively growing subjects. The arches should be well aligned. It can be used in class 2 diff 1 and class 2 diff 2 malocclusions, It can be used in class 3 malocclusions. It can be used in class 1 malocclusion with open bite or class 1 malocclusion with a deep bite. The lower incisors should be upright. The lower anterior facial height should be reduced, and it can be used as stage 1 of a fixed functional treatment therapy, and it can be also be used as a post treatment retention. Now the contraindications the androgen activator is, it is contraindicated in an arch that is crowded, is contraindicated in subjects with increased lower anterior facial height, and contraindicated if the lower incisors are proclined, and not suitable for non-growing subjects. Now the mode of the action of the androgen activator is as follows. The appliance fits loosely in the mouth. The patient protrudes the mandible, and this protrusion of the mandible causes stretching of the masticatory muscles, producing a myotactic reflex. Now this has the effect of restraining the forward growth of the maxilla, and it encourages the backward and upward growth of the condyle. Now, good patient compliance is necessary for the success of this appliance. Patients to be taught to insert and remove the appliance, and the duration of wear is nighttime plus 2 to 3 hours daytime. Now, the androgen activator can be selectively trimmed to achieve certain desired tooth movements as shown in the diagrams. Here we can see the activator is trimmed such as to encourage distal movement of the molars. Now the activator can be modified in various ways. Now one of the modification is known as a bow activator, which was introduced by Schwartz. Now it's split into maxillary and mandibular portions and is connected by an elastic bow. Now the effect of this modification is it allows a stepwise advancement of the mandible, and a screw can also be incorporated into the appliance for arch expansion. Now the another modification is known as the Wunderer's modification. Now this modification is used for class 3 malocclusions, whereby the maxillary and the mandibular portions are connected by screw. Now opening of the screw causes forward movement of the maxilla and a backward movement of the mandible. Now another modification is a reduced activator, or also known as the cybernator or Schmuth. It is similar to a bionator. The two halves are connected by an omega shaped palatal wire. Yet another modification is known as the propulsor. Now this was introduced by Muhammad and refined by Hodge. Now it is the combination of features of a monoblock and an oral screen, and this modification has no wire components at all. Now the palate free activator introduced by Metzelder, this has no palatal coverage, and because there is no palatal coverage, this appliance is very convenient for the patient. Now the Kawadzki modified activator has maxillary and mandibular portions connected by U-loops in the molar region. Now this again allows a stepwise advancement of the mandible, made possible by the adjustment of the U-loop. Now the mandible can be more mobile, and thus it is more convenient to wear the appliance. Heron-Shey modified activator. Now in this modification, the mandibular is overcompensated in its advancement, okay, and the clasps are incorporated into increased retention of the appliance. Now the activator can also be modified to accommodate headgear for orthopedic action as well, and two of these examples are a Tosher appliance and a Van Beek appliance. Now let's have a look at the function regulator, also known as a function corrector. Now this was introduced by Rolf Frankel, and thus it's also known as the Frankel appliance. The mode of the function regulator is as follows. Number one, it creates muscular function adaptation. Now, abnormal perioral muscle function is believed to impede optimal growth of the dentoalveolar complex. The function regulator holds away the muscles from the dentoalveolar complex. Now, this tends to increase the vertical, transverse, and sagittal intraoral space. It also improves muscle tones, prevents hyperactivity of the mentalis, and eliminates lip trap. It can also act as an exercise device, and Frankel advocated patient to do oral gymnastic exercises. Now the second mode of action is by way of mandibular protraction. The mandible is positioned anteriorly by the acrylic plate that contacts the alveolar bone behind the lower incisors. Now the lingual pad also acts as a proprioceptive receptor for the postural maintenance of the mandible. Now the third mode of action is the differential eruption guidance. Now the Frankel or functional regulator is free of contact of the mandibular teeth. Now this allows selective eruption of the lower buccal teeth, and the lower buccal teeth erupts in the upward and forward direction, which tends to correct a class 2 malocclusion. Now the function regulator can be divided into various types. Okay, we have the function regulator 1, which is subdivided into 1A, 1B and 1C. You have the function regulator 2, 3, 4 and 5. Okay, now 1A is used in class 1 cases, class 1 with deep bite, class 1 with mild and moderate crowding. The 1B is used in class 2 diff 1 with an overjet equal or less than 5 mm. The 1C is used in class 2 diff 1 cases with overjet more than 7 mm. Now the FR2, the most commonly used type, is used in correction of class 2 diff 1 and class 2 diff 2 malocclusions. The FR3 is used for class 3 malocclusions. FR4 is used for open bite and bimaxillary proclination cases. FR5 is used with headgear for vertical maxillary access or long face syndrome. Now, the function regulated 2 of Frankel is the most commonly used type of function regulator appliance. Now there are two groups of components in the appliance. One is the acrylic components, which consists of buccal shields, lip pads, and lower lingual pad, whereby the wire components consist of a palatal bow, a labial bow, canine extensions, upper lingual wire, lingual cross wire over wire, and support wire for the lip pads. Okay, so here we can see some of the components of the FR2. Okay, now the FR3 of Frankel is used in class 3 malocclusion caused by a retrognathic maxilla and a normal mandible. It can be used during the deciduous, mixed, or early permanent dentition stage. It has two upper lip pads which eliminate the restrictive effect of low upper lip on an underdeveloped maxilla, exerts tension on periostal attachments in sulcus depth to stimulate bone deposition. It transmits upper lip force to mandible via lower labial arch to restrain mandibular growth. So here you can see a diagram of the FR3. So in this FR2, this lip pad is in the lower, whereas in Frankel 3, FR3, it is reverse with the lip pad is in the upper arch. Now the Bionator was introduced by Baltus in 1950s. It's similar to the Activator but is less bulky and more elastic. Now this is the three types of Bionators. One is the standard Bionator, number 2 is the class 3 or reverse Bionator, and number 3 is the open bite Bionator. Now the standard Bionator is used for class 2 DIF1 and malocclusions and class 1 malocclusions with narrow dental arches. It has two groups of components. The acrylic components consist of the maxillary acrylic part, mandibular acrylic part, and the interocclusal acrylic part. The wire components consist of the palatal arch and the vestibular wire. Now class 3 or reverse Bionator is used for class 3 malocclusions caused by mandibular prognathisms. Now the acrylic components are the same as the standard type of Bionator, but the wire components are different. The palatal arch is placed in opposite direction as compared to a standard Bionator, and the vestibular wire runs over lower incisors in the standard types, whereas the vestibular wire runs over the lower incisors in a reverse Bionator. When compared to the standard type, it terminates at the lower canine. Okay, here we can see a diagrammatic representation of the different types of Bionators. Okay, this is the standard Bionator. This is the open bite appliance, whereby you can see the wire is running in the middle, which has the effect of blocking the tongue. And this is a class 3 or reverse Bionator, whereby this palatal arch is reversed when you compare with the standard type. Okay, as well as the labial bow runs over the lower incisors, whereas in the standard type it terminates at the canines. Okay, the open bite appliance is also similar to the standard type of Bionators, but it is modified such that the maxillary acrylic part covers the anterior area, thus helping to prevent tongue thrusting. Okay, the twin block appliance. The twin block appliance consists of upper and lower plate with occlusally inclined bite planes. Now this bite planes causes a functional mandibular advancement, and this appliance can be combined with headgear and a concord face bow. Now screws can also be incorporated into the upper plate for arch expansion. Now the twin block appliance is supposed to enjoy a good patient acceptance because the bite planes offer greater degree of movement in anterior and lateral excursion, and there is less interference with the normal oral functions. Now the twin block can also be modified into a fixed twin block, whereby the appliance is directly bonded to the tooth surfaces and cannot be removed by the patient. Now the Herbst appliance was initially introduced by Emil Herbst in 1905, and then it was forgotten and it was reintroduced by Punches in 1979. Now it is a fixed functional type of functional appliance. It consists of a bilateral telescopic mechanism which keeps the mandible in a continuous forward position. Now the indications for the Herbst appliance are class 2 malocclusion due to a retrognathing mandible. Can be used in post-adolescent patients. It can be used in mouth breathers and uncooperative patients. There are two types of Herbst appliance. One is the banded types, whereby you have bands on the upper sixes and lower first premolars. The other type is the bonded type of Herbst appliance. Now, the advantages of Herbst appliance is it is continuous section since it cannot be removed by patient, shorter treatment duration, it's less dependent on patient cooperation, and it's more successful in patients who are at the end of the growth phase, and it's also useful in mouth breathers who have the habit due to nasal airway obstruction. Now the disadvantages of the Herbst appliance are there is an initial discomfort until the patient becomes accustomed to the appliance. There may be minor temporary functional disturbances. There may be possible temporomandibular dysfunction, and it may give rise to repeated breakages and loosenings of the appliance. Now plaque accumulation may also cause enamel decalcification, and there's a tendency towards an posterior open bite. Now the Jasper jumper is also a fixed type of functional appliance, but it's a flexible fixed type of appliance which is tooth borne. It was introduced by Jasper in 1980. It is similar to the Herbst but less rigid than the Herbst. It consists of stainless steel coil attached at both ends to stainless steel caps. The spring has a polyurethane covering for comfort and oral hygiene. It's attached to the maxillary posterior region and to the mandibular anterior region, and is usually used together with fixed appliances. Now the Jasper jumper is indicated for class 2 skeletal class 2 cases due to maxillary access and or mandibular deficiency. The advantages of the Jasper jumper is it gives rise to continuous forces, is not dependent on patient compliance. The degree of mandibular freedom is greater when compared to the Herbst, and is easier to maintain oral hygiene when compared to the Herbst. Now what are the effects of the Jasper jumper? It has got skeletal effects and the dental effects. Now the skeletal effects are basically The appliance holds or moves the maxilla distally. There may be a slight shift of the A point. There will be clockwise rotation of the mandible. The condyle moves forward, whereas the dental effects consist of posterior tipping and intrusion of the upper molars, backward tipping of the upper incisors, anterior tipping of the mandibular teeth, and intrusion of mandibular incisors. Okay, these are the references for the lecture today, and thank you.